we're going to change gears a little bit, talk about sort of an area that I think everyone feels very passionate and is interested in, and it's exciting for us because it's a new topic for us. Sort of the food as medicine, and we've talked a lot about social determinants of health and population health and how health systems and community health systems should work together to kind of bring that to light. And we've got some folks here who are really doing the work and getting the programs on the ground and getting funding for them. I don't know if you all saw, I think it was in November, that the administration funded a big movement in terms of food as medicine. So there's a lot of momentum behind it, and we're seeing a lot. So it's an area that we're going to start to focus on quite a bit. So we're excited to have this group to tell you about their work and see how we can get it more, spread throughout the community.
Thank you. I'm Dr. Kimberly Noel. I am also a board-certified physician in preventive medicine, so I'm very excited to talk about this notion of food as medicine. We touched upon this. There are a couple big movements, right? I think the COVID pandemic highlighted a very important disparity in regards to food insecurity. And the government, the USDA estimated 11.1% of households, or 14.5 million households, were food insecure. And the White House announced more than $8 billion for commitments to food as medicine. And so I think that this is a really timely conversation to have around the work that you are all doing and representing different organizations. So I'd love for you to introduce yourselves, introduce your organizations, and give a short synopsis of an introduction.
Sure.
Or should I? Are you guys all mic'd?
Yes, we are. Yeah. Good morning, everyone. I'm really pleased to be here. I'm excited to talk about the work that we do at New York City Health and Hospitals. My name is Rupa Kalyanaraman Marcello. I lead population health research and evaluation at New York City Health and Hospitals, which, as you probably know, is New York City's public hospital system. It's the largest one in the nation. We serve more than 1 million patients each year, primarily low income. About a third of our patients are uninsured, and another third receive Medicaid benefits. So it's a really very high need population. And as I think all of you know, our system was hit probably the hardest in the city by the COVID pandemic. It was just a really, the prior talk about physician burnout is just so applicable to our system. We were really hit hard by it. And a lot of our families, as a result, were facing food insecurity at levels that are far higher than before the pandemic. On my team, I lead initiatives to improve healthy food access and to improve nutrition among children. And so thinking about food as medicine, it has become such a hot topic. But the work that I do specifically is really, I want to call it food for health. Thinking about that preventive approach rather than solely working with adults who may have multiple chronic conditions, but shifting that paradigm and moving it back earlier into the lifespan so that we can prevent these chronic conditions, which can be prevented and modified through diet. So to that end, I work to improve the organizational food environment through the foods and beverages that are sold and served. And also I'm leading several produce prescription programs that are focused on pediatric populations who are at risk of health problems later in life. These children have overweight and obesity. And these are really innovative programs. They're the first of their kind in the nation. We're sending fruits and vegetables to the homes of families with young children because we know that early childhood is an incredibly critical time for shaping dietary habits and establishing healthy habits for the lifetime ahead. And so rather than intervening with older adults who might have diabetes that's diagnosed or hypertension, we're working with children with overweight and obesity to sort of stop that cycle, to help them develop healthy habits, to learn to love fruits and vegetables when they're 3, 4, 5 years old, so that we see lower rates of diagnosis of diabetes and hypertension, hopefully in the future. And I'll just speak really briefly to some of the work that my colleagues do, and Dorella will speak to this a little bit more. But we do have some programs in place where we do partner with God's Love We Deliver on sending medically tailored meals to our older patients who are medically complex. And we also work to enroll patients in SNAP and WIC where available. So we have a pretty a broad range of programs and initiatives to address food security, but also nutrition security, which is sort of, I think, a newer concept. So not just thinking about the availability and access of food, but food that's nutritious and health promoting. Because lots of families do have food access, but it may not be nutritious food. So we're working to improve both food and nutrition security in a variety of ways across our system.
And hi, everyone. I'm Duria Walters, and I'm the Senior Director of Business Development and Community Partnerships at a nonprofit here in New York called God's Love We Deliver. We started as a direct response to the HIV/AIDS pandemic more than 30 years ago, and in 2001, we expanded to serve other diagnoses. We have always seen as our core competency addressing food and nutritional needs and helping an individual through the trajectory of their illness. So we have started partnerships with healthcare through contractual relationships in 2005, and I'm responsible for those relationships. We are contracted with all of the insurance plans in the downstate area, and we anticipate expansion to the whole state. What we are concentrating on also is that we're the lead agency of the Food is Medicine Coalition, which is a national organization of other medically tailored meal providers across the country. We are serving the 5% of individuals that cost healthcare 50% of all dollars, the sickest of the sick. Our intention is to make sure that those individuals, regardless of their financial status, are able to have access to proper nutrition in order to address their illness and especially to be able to tolerate their medications and their treatments. So our population at God's Love, 90% of them are living at or below the poverty line. We do not charge for our services, and our intention is to really be part of the plan of care that healthcare, that clinicians are thinking about when they are wanting to provide treatment to their patients. So one of the things that really came out during the pandemic is that not everyone was asking food insecurity questions. No one was screening for that. And oftentimes, clinicians may not ask those questions because there's a concern as to what if the answer is in the affirmative, what will I do, where will I send them? So while we're serving this spectrum, right, the sickest of the sick, we work very closely with all kinds of service providers in the city and in the country to make sure that if someone needs enrollment in SNAP, if someone needs access to groceries or anything like that, we're part of that continuum of care. We're not a forever program. However, we are serving some diagnoses that, their end of life is ending with our program. We have always seen it as essential to not just serve the person that is dealing with illness, but also their children and also their caregivers. We saw a huge surge during the pandemic. We were deemed an essential service provider, so we did not stop our home delivered services. We just had to modify the way that looked. But it's key to have healthcare really think about how do community-based organizations support your patients and have collaboration, have a key methodology of communicating with each other so that if something happens in the community, the hospital or the clinician is made aware. So, super excited to be here with you all. Anything else?
Thank you. So, hi, everyone. I'm George Pachid. I'm the president and CEO of Services for the Underserved. We are a large health and human service agency in New York City and Long Island, providing an array of services across the continuum of behavioral health, so mental health, substance use services. We run supportive housing, shelters, and we have a large footprint around individuals with developmental disabilities. So unique in terms of the conversation. It's super exciting to be here. And also as a psychiatrist, being sort of in this food justice space is really interesting because we are not a healthcare system. We are not an agency that is devoted specifically to the issue of food, but as we view everything through a social justice lens, food security is really critical, right? We recognize and identify, and certainly I think COVID demonstrated the high rates of food insecurity among the people that we serve, their families, and also amongst our staff. We just did a food survey. We did a survey of our people served and the folks that work at SUS, and we have over 30% of food insecurity. And as an employer, that's gut-wrenching that I've got staff that are food insecure, perceived to be food insecure. So part of what we've been doing, and I think why we're in this space, is that in many of our buildings that we manage or run, we have urban farms. So we have 70 locations across the city. Last growing season, we grew over 9,000 pounds of fresh fruits, vegetables, herbs that engage the local tenants of the building, engage the community, and create volunteer and or employment opportunities for folks. So we're not necessarily solving the issue of food insecurity per se, but we are certainly working at it and recognize the importance of this. The idea of prescription produce or medically tailored meals is really critical, and one that I think we as a Health and Human Service agency, primarily focused on individuals that have significant challenges, is critical for us. We opened up community fridges because we recognize the need in our communities to be able to do that, and we work with individuals served in our developmental disability program to be the stewards of those community fridges and cleaning and restocking. And what we have seen is a huge outpouring of support from the community and need in the community. So we're about to launch another 3 or 4 of them, and this is not something that we're getting funding for. We're just doing it because we have to. It's a moral imperative for us to be able to tackle this among all the other challenges that we have. Because again, I do think that this is, from a social justice perspective, an area that we have to really be focusing our attention on.
Thank you so much. So we have a great panel. I would like to follow up on a conversation that we actually started this morning about food justice, right? And I think we could, when we look at the economics, it's not that we can't serve those in need, but we can't necessarily manage the waste of wealth in regards to food access, right? And so in terms of even events such as this, like corporate events that have a lot of food, there's so many barriers to being able to get that food to people in need. How are you addressing those partnerships to be able to link the wealth of our country to those who need food assistance?
Yeah. Do you want to take that first?
Yeah. So for us, it's so we're trying to create different types of partnerships. We obviously work very closely with many of the food pantries and other sort of local community-based organizations to help in some of the initiatives that we have going on. But I do think it requires a much more concerted effort across the different systems. We can't do it in isolation. But I also think that we focus on availability and access to food. But I think we have to think about people's preferences. And the really interesting thing when we surveyed people served, we run shelters 24/7, right? And obviously we provide food, 3 meals and a snack. The rates of food insecurity in our shelters were higher than we had anticipated, considering that they have access to food. But I don't know that it's necessarily, and this is my own speculation, we're going to do a deeper dive, but I don't know that it's of their personal preference. They don't have agency around when they eat it, where they eat it, how they eat it, and what they eat. And that's problematic. So I think we have to really be thinking about the systems writ large and where, city government, state government, where all of those different, even plans sit in terms of thinking about how we're going to resolve these issues. So I don't know if that answered your question, but I think it's about the right partnerships and having all of those players at the table.
Yes, and I would just support that and say, so we generate a lot of meals. In a year, we're delivering 3.2 million, right? And we have sometimes excess, sometimes people aren't home. So we partner with organizations to hand over those meals and make sure that people have something to eat. And yes, people should have agency and be able to eat what they want to eat, right? But also have education, right, from our team of registered dietitians or all of these wonderful students that we have across the country that are able to help educate how food is related to your health and how food is related to, prevention of disease.
I'd like to pivot back to Rupa because you are really helping our youngest populations develop those tastes and preferences and creating that link. Can you comment on how important it is to address desirability maybe of food and also build the opportunity for them to eat healthier?
Yeah, so I'll just a quick background on this produce prescription program study we were running. So it's called Food for Health, which I think I mentioned. We were very intentional about choosing this name instead of lumping it in with food as medicine, because that to me is a very reactive approach. Food is medicine, treating people when they're already sick. And our goal really was to stop that and shift the paradigm to promoting health, preventing disease. And so we launched this study last year. It's a randomized controlled trial. It's the first of its kind in the nation. And we're enrolling children who are ages 2 to 8 who already have overweight or obesity. So these are children who are at risk of developing chronic diseases later in life. But and when I say later in life, I don't mean when they're 30. I mean when they're 14 or 15. We're seeing teenagers and adolescents in our pediatric clinics who have obesity already, who are well on their way to developing type 2 diabetes, who have non-alcoholic fatty liver disease. And so we really want to address their health and their diet earlier on. And so what we're doing is we're home delivering fruits and vegetables for 6 months to these families. It's partially to address food insecurity, but really also to ensure that there's a diversity of fruits and vegetables present in these families' homes. And so getting to what Daria was saying about culturally appropriate foods, one of the things we were very intentional about in this program too was working with a farm partner who allowed for choice in constructing these boxes. A lot of produce prescription programs work with farms who just give people what's available. It's like a typical CSA model, right? Like you pick up your box every week and you get what's in there. And you might not like what's in there, you might not know what to do with what's in there. And so that's a challenge for a lot of these families. And as you know, H&H serves an extremely culturally diverse population. At the hospital that we're running this program at in Queens, we have a very large South Asian population and a Caribbean population. And so we want it to be responsive to the types of fruits and vegetables typical to these cuisines. And so families are able to customize the fruits and vegetables that go into these boxes. We know from prior research that choice is a very big priority for families who participate in these types of programs, but it's not always feasible based on the farm partner or organization that is being worked with. So we were very intentional about that piece. So we could provide families with things that they are accustomed to. Again, we want to provide things that are new to them, but not everything, because then it's not going to get used and it's not going to get eaten. So we were very intentional about that in addressing what we had seen as barriers to prior programs in engagement and use and consumption of fruits and vegetables. And similar to that, I spoke about our work that some of my colleagues across the system are doing with regards to food insecurity. We have a program what's called Food Navigation. And so these are people who screen families or patients for food insecurity. We refer them to SNAP or WIC enrollment, but also to community food resources. And we've also been just much more intentional about recognizing the work that our community food partners do in providing culturally appropriate foods. And I know that a lot of partners across the city are working to address that as well. Like the Food Bank for New York City is working to improve sort of what they stock in terms of being culturally appropriate for the diversity of communities across the city. But I think that we still have a long way to go in recognizing that is a reason that people aren't necessarily availing themselves of some of these resources.
I want to add a different tangent. I have done work at 23andMe, and a lot of people use our product to find out their ancestry. And part of our journey into thinking about healthcare is like, can we inspire people to learn, as they're learning about their ancestry, to tap into healthy cultural eating habits that are innate? Like a lot of foods from sub-Saharan Africa are gluten-free or have, promotion of fresh fruits and vegetables as part of a lot of Latin American cultures, et cetera. And so are you able to tie that self-discovery and celebration of culture into food preferences? Yeah. So I wanted to ask about how this is a great example of how you are taking into consideration people's culture in promoting food security. How about in your organizations? How have you addressed the diversity of communities you serve?
So for us at God's Love, everything is designed by a team of registered dietitian nutritionists. We are very cognizant to make sure that the menu is as diverse as possible. So if you were to look, you've got a regular, you've got a vegetarian, you've got a pescatarian, you've got, like all of those options. The goal is to create as much variety as possible. So everyone gets a nutritional assessment by the dietitian and ongoing nutritional counseling and education. And we make sure that all of the clients are exposed to different kinds of foods, right? So if you're Latina, you're kind of like, what is quinoa? What is that? So the dietitian has to educate them at what that is and why that may be beneficial for their overall health. right? It's about learning new things, trying new things, but also honoring what they recognize, perhaps as new immigrants to the country, all of that. And it's constantly evolving to make sure that we are recognizing the cultures we're serving, but then also the diagnoses that we're seeing, right? About 40% of our population is dealing with 4 or more comorbidities in addition to their primary diagnosis. So there's a lot of dietary modification that needs to happen, and we still want to make the food enjoyable to them. So that's our plan.
Yeah, so for us, we've been very intentional about in each of our urban farms is to engage the folks that are in the community and making sure that they're, thinking about it. And right now, we're actually meeting with the folks and thinking about what are we going to plant, next season, right? So it's really the issue of choice, I think, is really critical. So that community is clear about what's going to be grown next season. And again, it's for us. These are small, in some instances, smaller plots versus larger plots, and we're not able to really cover all of the needs, but we are engaging them in having these conversations, helping them understand, going from seed to, cultivating something. But then what do you do with it, right? So it's like, for many, they might not know how to deal with kale. Like, what do you do with kale? Do you saute it? Do you whatever, right? So we are very intentional about the types of educational programs that we provide. And again, these are individuals that are facing significant challenges and multiple comorbidities as well. So to think about how do we do this in a way that's really conducive to where they're at in their recovery journey, and then providing them with the necessary skills to cook it, but also, like, do they have the right utensils? Do they have the right cooking things? So we have to really be very comprehensive about this, because you can give them a box of things that they want, but if they don't have pots and pans and access to a stove, like, these are all the things that we are grappling with to make sure that we're covering all of it. So it's not just they're getting it, but that they're able to do something with it, and that it is very much culturally syntonic to where they're at. So it's a challenge.
I think it's really interesting in terms of God's love we deliver, because the deliver part is a big aspect of getting food to people, right? And navigating that link between production and the community, whether it be through farms or through initiatives that are health system based, are important. We've also seen in the pandemic some interesting partnerships. I know Microsoft and Kroger were thinking of how they would address, the needs of people who test positive for COVID, that they ultimately cannot. We don't want people who are positive to be in the supermarkets, and kind of thinking innovatively of how to make links that way. Yeah. This brings me back to the conversation that a lot of doctors might want to use services like yours.
Yes.
But it's so difficult to have links with the social work systems within those hospitals. So how are you working to, you're within the health system, so you're an advocate within the health system. From the community side, how are you both kind of embedding to find each other?
Sure. So I'm seeing that there are lots of independent practice associations popping up all over, and they are partnering with insurance plans. And those insurance plans that are thinking innovatively are trying to look at ways to improve overall health outcomes, right? Lower the cost of care. So we are in value-based payment partnerships. Some of the big players are the Metro Plus health insurance system, which is the city's plan, and then you've got others. The list is long, but it's about really thinking, well, how do we make sure that the clinicians know that this is available? So that's been an interesting process, right? Because sometimes a doctor may only have their office assistant and only so much time with the patient. So what we've tried to do is help them ask short screening questions. If it's in the affirmative, then just send us the details and we'll feed them. And I think we've been seeing some real kind of light bulb moments for those staff, so that they are like, oh, the patients are happier, they're doing much better, their A1C is improving, et cetera. But they never would have referred to us through our normal philanthropic pathway. So I think that's an interesting struggle in terms of the institutional memory, that while we may present to a team of social workers or case managers in one spot or one department, that knowledge isn't moving through the entire facility or the health system as a whole. So the goal is to try to leverage insurance plans, but also hospital administration, and embed the knowledge in the whole system, so that if there's an innovative opportunity, if there's a grant opportunity from a foundation, everyone understands that they will have the ability to refer for this type of program. And one of the things we've recently done is enter into a business associate agreement with NYU Langone, and we're moving to Bronx here as well, so that the selected physicians can simply sign off on the eligibility of particular diagnoses. So that's your oncology unit, that's your cardiology unit, and it's just easy referrals wherever the social worker or the dietitian may be on the floor. So that's us.
Yeah, and since you mentioned, IPA, so I ran before going to SUS, one of the largest behavioral health IPAs, and we're, regrettably, and that's a whole other topic, right? Regrettably, I don't know that there's necessarily at the plan level an emphasis on some of the behavioral health spend, and where, community-based providers like SUS and others have a say in where we're thinking about value-based payment. But I do think that it is a responsibility for the state who controls the plans and the plans to think about food and housing as healthcare, right? And Medicaid dollars need to flow to that. Otherwise, we're losing an opportunity to be able to really impact differently. So potentially someday down the road, there might be some value-based payment that includes behavioral health providers and thinks about food, much more specific, or even housing. And there are states that are doing this, right? I mean, North Carolina with their 1115 waivers looking at, food as sort of a covered service. We have to move the system in that direction. And again, I can go off the deep end on some of my issues around plans, but I do think it's about really, again, bringing stakeholders to the table, helping them understand what the return on investment would be. If we can get, kids healthier earlier, we would prevent time horizons for plans aren't 14 years. It's 12 months because of churn. So there's a whole bunch of, but going back to the question is, I think it's about really having these conversations, looking at the partnerships, thinking about how we have. For the first time, I think we're talking about food and housing and other of these societal imbalances in a way that is firmly rooted in the healthcare system. And I think that that's important because, again, it is a social justice issue. If we can get people a roof over their heads, if we can get people, safe, sufficient, nutritious food, we will save the system money and we will be doing what we need to be doing. It's the right thing to do. That's just my perspective on it. But
But I'd like to dig into that because I think it's really important in terms of trying to prove the link, really understanding social determinants and the cost savings potentially at the end. Because on the other side, people may see that there's individual responsibility, right? Teach someone how to fish, they eat for the rest of their life, and give them a meal, then. I butchered that, but you get the parable. The point that I'm trying to make is that the example I gave was of Kroger and Microsoft, looking at the consumer, and yet as healthcare providers, as people who work very closely with the sickest populations, we understand the nuances and complexities that are more than just the access to purchase food, right? So I guess, how are you able to advocate for food security as a health issue? Is it the role of the hospitals? What do you say to people who say, no, it's personal responsibility and healthcare is already too expensive? How do we prove the return on investment for food?
Yeah, I will say that I think some of that is shifting a bit because there are studies that show the cost benefit and the return on investment of food as medicine programs, especially. And we have the most evidence for medically tailored meals, and I'll let you speak to that because you're the expert on that. But we know that when we provide these sickest individuals with nutritionally tailored meals, it does improve their health. There is a cost savings in terms of their healthcare utilization. But that is, it's this small proportion of the population, and I think where we're moving to, and we're seeing these new investments, especially in the past year, from the White House commitment, to foundations like the American Heart Association, the Rockefeller Foundation, investing in food as medicine to generate this research so that we can say, just as definitively as we are able to now with medically tailored meals, to say, look, we're investing in studying these programs. We can show definitively that when you home deliver produce for 6 months to this type of patient, we will see this change, and it is cost savings. There is a return on investment. But we don't have those types of studies just yet, and I worry a little bit about that reliance on these types of studies, especially when it comes to children, because with medically tailored meals, these are the sickest people, and so they have high utilization, and they are very costly to the system. I think you said it was like 50% of costs. Yeah. And so, of course, you'll see this reduction, but we're not going to see that with young children. Like 4-year-olds with overweight are just coming in for their primary care visits. Unless they have something else that's going on, they're not going to come in for ED visits or specialty care. And so it's very challenging to show that return on investment. It's challenging to track people over time. And I think one of the things we need to think about is how do we creatively and strategically tell the story of why this is a valuable return on investment, even when we are not going to be able to say very concretely, yes, here's the dollar value, and therefore health plans should reimburse for this. Because in the long run, it will save us money, save us sickness, disability, and death. And so I think I might have rambled away from your question, but I think the challenge is we are investing in this research, but we need to think about how we show the value of these programs when it's with populations who aren't already sick.
Yeah, I agree completely. And I think for this group to know from a national perspective, there's a medically tailored meal bill out there, HR 5373. And the president, touted it in at the White House conference. The goal should be, there should be a collaboration between hospitals, clinicians, healthcare, foundations, community-based organizations, definitely, because if someone is not stably housed, then none of it matters. Nothing holds strength. And all of it requires collaboration. Everyone should be interested in changing the way people have access to food and nutrition services. If it showed up during the pandemic that once people were either losing their jobs or people were getting sick, someone gets sick in Texas, in a part of Texas that doesn't have a program for when they're on chemo and radiation, how are they handling that moment for themselves and their children? That should be something that we're all interested in and concerned about, because we want them to do well with the treatment. But if they can't do that or tolerate it or take care of their own family during that season, then it is our fault as society, right? This is the justice question. So I definitely think that it requires all of these systems, which I'm sure you all saw the tough study in JAMA. Like, everyone needs to be part of the solution of looking at what are all of the social determinants of health, how do we collaborate on that, and healthcare cannot do it by itself, right? There are these strong organizations in the communities where your patients are living. Partner with them, leverage that opportunity, right? Sometimes there's this misconception that a community-based organization couldn't possibly help to move the needle. But there are stories about that. Foundations know that already. So how do you bring all of those groups together?
Yeah, I agree with everything that was said, but I do think that it's important to also think about this from the perspective of, there is a sort of an underlying systemic racial inequity that I think is part and parcel of the issues, right? When we talk about Black and brown communities and the disproportionate impact that a lot of these sort of imbalances have created, I think we have to talk about that, and we have to sort of rationalize it in the context of, it's about dignity, it's about access to, what anyone else would require or need for their own family, that it's not about pulling yourself up by your bootstrap, right? When you've had, so many, decades of systemic inequity. So I think it's about also recognizing that and calling that out. But I do think, I think that the White House conference was great, but it's the second one in 50 years, correct, right? This is something that we should be doing every single day. I'm exaggerating, of course, but we really need to be thinking about this constantly because it is critical. But I just think that sometimes it gets skewed by some of the other conversations that are happening in healthcare where this does not seem as relevant or as important. But I think we need to elevate that, and we need to continue to push on this issue.
As experts in this space, some might say, I just brought up the example of corporate events or restaurants, and can't you just give the food away? Yeah. There are homeless people on the street, and we understand that health concerns, there's a lot of parameters around food donation. Mm-hmm. What are the opportunities to kind of leverage reducing waste in a city as wealthy as New York City?
I'll start by saying charity is great, but it's not a substitute for justice. It's a Band-Aid. It is not a solution, right? You're bleeding. Like, what's this little Band-Aid going to do for you, right? Like, let's prevent you from falling and cutting yourself open in the first place. And so, I mean, I think, I've observed over the past several years, especially during the pandemic, there are all these organizations opening up to sort of rescue food from organizations and deliver them to pantries. But those are stopgap measures. That's not, I always hear people say our food system is broken. I don't think it's broken. It was never set up in the right way. Broken implies that it actually worked. It didn't work. It's not structured in a way to promote justice and to serve everyone equitably. And so I think that we are seeing this proliferation of these types of organizations to minimize food waste. But that cannot and will not be the answer. We need to really think about, as both of you have spoken about, just sort of these foundational things and thinking about food justice and sovereignty and equity, and working across sectors and thinking creatively. And it requires a much bigger effort than just any one sector can accomplish individually.
Yeah, I mean, we just recently did some geo-mapping of some of our shelters and supportive housing, and they're in food deserts, right? It's a quarter of a mile distant from any access to food, and that's problematic, right? We have hundreds of sites across the city. So think about how do we rationally look at where an individual is living and what access they have to food or not, and then we think about the gentrification of some of the neighborhoods that we're in, and how I just found out eggs are. My son has allergy to eggs, so we don't buy eggs, but they're $10 a dozen. Like, I was shocked. Again, we don't buy it because we have allergies at home, but it's how do you afford that, and how do you think about a way of mitigating some of those cost issues that I think are plaguing everyone right now.
I think that's a really great point. And you were just talking about, as an employer, you're seeing employees starting to be affected by food insecurity. Inflation is, economists monitor inflation by costs of common groceries. How are you buckling down for this uncertain economy? What are your plans to kind of weather this storm of increasing food insecurity?
We're just going to keep going. We quickly saw increased costs, food costs, because we're buying in such large quantities, and we had to call our board together and really look at what is going to be the strategy. We probably have to touch our reserves and just move through this season, but if we're feeling it, then the people that we serve are feeling it. So we are seeing an increased number of people being referred to our program because they both can't afford food, can't stand there at the stove and cook it for themselves. Right. So it all ties together.
Yeah, I think for us as an organization, it's thinking about how do we. And there's been a lot of influx of dollars into the behavioral health system, which has been great. We had our first cost of living increase in probably 10 years. Not going to solve the issues, but we are able to make slow incremental changes in people's salaries, not to the degree that I would like, but we're certainly looking at other ways of building out some of the benefits that employees receive at SUS. But I think it is a challenge. I think it's about valuing the work that we do. When we have a direct service provider working with an individual with developmental disabilities, that should be paid well because they're managing and dealing with a situation that no one else will and does. So, all frontline workers, I think, need to be paid better. But it is looking at, talking to your board, figuring out, if we're going to be losing money, what do we do? So it's a fine balancing act, but I think we've been lucky to see some glimmers of hope with not only the feds, but also at the state level with Hochul and some of her proposals for mental health and bolstering the system as positive signs that we might be able to, help the workforce, which is really struggling.
Yeah, and I'll speak to that a little bit. Obviously organizations are different, but one of the things that Health in Hospitals has done recently, and you may have seen, is that our inpatient meals have been switched to a default of plant-based meals. So patients are offered their first choice is a plant-based meal. The second is also, and then the third is, if you're an omnivore, you can pick that. But these are all culturally representative meals as well. I mean, and they're amazing. I've tasted some of them. But part of that too is thinking about sustainability and cost. Our teams who work on inpatient dining have seen that their costs have been reduced by shifting to predominantly plant-based meals. But sort of thinking out to the patient side of it, right? One of the things that our teams are doing too, and I do not oversee any of this, but I work closely with these colleagues, is to provide these recipes and information to our patients so they can make these when they go home.
Yeah.
So that they are nutritionally appropriate for our patients, but they also include things like dried beans, legumes, fruits, vegetables that will be cheaper than animal-based products. So sort of, while we don't primarily address this, we are giving them resources so that when they are discharged, they can feed their families in a way that's nutritionally, culturally appropriate, and cost savings for them as well.
That's amazing. I want to thank our panelists for their amazing work in this space. Honestly, it is a pleasure.
Thank you, everyone.
Thank you.
Thank you.